Okay, thank you guys again for coming back so quickly, sitting down. Our next panel is one that you guys should be very excited about. These are the people that fund recovery residences. So we brought together the two MSOs that serve a majority of Colorado right now, Daniel Darling, Tanya Moser, and then Jamie Feld represents the Attorney General's office. She's going to be talking a little bit about the opioid settlement funds. And then Mark Condagiani at the end is the Director of Recovery Programming with the Behavioral Health Administration now, or the BHA. I'm going to go ahead and turn it at this time over to Daniel, and thank you guys again for your cooperation and coming and participating in the summit.
Well, good morning, everybody. It's good to see you all. Looking forward to having a great panel here today. I learned about 48 hours ago that I was going to be moderating this, which is way too much power probably to give me. And this is going to go badly, but I plan to give all the hard questions to the rest of the panelists, so that actually works out. The other goal I'm going to have is to try not to roll off the back of this stage, because there's a pretty good precipice here. But it's good news because we have CARR here to help regulate the health and safety of our presentation, so that's going to be good. Yeah, I know. That's why we need one of those ladders, right? And if it gets too rough, we're going to come back to that slide because that generated a lot of enthusiasm as well. So, but in all seriousness, it is really good to be with you all today. I think the growth of access to recovery living has been one of the most remarkable things in the last couple of years, especially in Colorado. It's hard to know like how close we are to what we need totally in the state, but I believe the answer right now is a whole lot more. And there's a lot of working together that we have to do to get there. So I have a couple of brief slides, and then I'll kick it to the rest of the panel. Should we do more introductions, or just go as we go? As we go? Okay. All right. We took a straw poll. We're going to go as we go. All right. I'm Daniel Darting, CEO of Signal Behavioral Health Network. Signal is an organization that is designated by the state of Colorado in contract with the Behavioral Health Administration to serve as a regional entity to support access to substance use disorder treatment and recovery services. And that includes supporting the state's plan around growing access to recovery living as well. Our goal and our approach is to work with local community providers everywhere where we work. So we're not, as an organization, directly involved in delivering services, but rather working with the right community-based partners. I have our website if you want to learn a little bit more about us, and Tanya is actually going to talk more about the MSO system, so I'm not going to say the same thing twice. She'll do a better job anyway.
I was hoping he would do it, and I could skip.
Yeah. Nope, sorry, I'm moderating. I hit the wrong button. Real quickly, kind of like the high level of where I think about there's been an arc of how recovery living access has grown in the state over the years. Many years ago, actually Aspen Point at the time, now Diversus, partnered with the Office of Behavioral Health, or was it ADAD back then, Mark? Was that an ADAD era? DBH? What was the name back then?
Started with
ADAD, okay, all right. Lots of acronyms. But the Access to Recovery, or ATR grant, which was one of the first opportunities for scholarship in recovery living access at the time. And then there is this thing called CARR that's come into existence after legislation championed by Representative Kennedy, among others, in Colorado, to really bring that certification and standards framework, I think, which gains. Which helps to gain increased perspective and trust around the recovery living service and programming that's available. Oxford Houses had been operating for some time in the state and was probably at the time probably the biggest, or still potentially is the biggest in terms of number of houses. But there's a huge number of more organizations, many of whom I'm getting to be here together with today. And I think there is so much more growth in organizations that's happening. During the COVID pandemic, the state immediately identified the importance of devoting resources to allow for continued access to recovery living when economic chaos was rampant. And that was a major catalyst for being able to grow access to scholarships in general. And I think the goal is to really continue to bring consistency and strategy to where that's going to go into the future. And I'm sure Mark's going to talk about that, so I don't want to steal your thunder. The master plan coming. I think from Signal's standpoint, our desire is to be stewards or equip access to care, access to recovery living, but we don't want to infringe on the importance of the identity of each recovery living community and what makes everyone unique and focused in what they're seeking to do. And there's requirements and regulation that we have to be accountable to, but it's our desire to be minimal in that approach. And I think that's something that has to be iterative. We have to get better at that. One of the things that has been very much appreciated is the contributions of feedback that we've gotten from a number of recovery living organizations. And to the extent that we have an opportunity to get some of those thoughts here today, or on an ongoing basis, that's our desire. We're not like, we don't have this all figured out. We need help to make it work the right way. I guess I'm combining. I'm a PowerPoint minimalist. I'm sorry. I kind of just I don't do good following my slides. I think we really want to be collaborators in designing sustainable funding that is built in a way that allows for there to be access in all corners of the state to recovery living, and also that it meets the demand that we have and is able to grow the number of recovery living communities to be able to reach that. And that's a big, tall order, and we don't want to get ahead of our skis, and we want to stay in the right collaboration with what the Behavioral Health Administration is really doing strategically too. So I think we might come back to a little bit of this as we discuss. So I might move forward. These are kind of prompting questions to maybe talk about as time allows. But Tanya, I think I'll turn it over to you.
Good morning. I'm Tanya Moser. I am the director for the Health Network and the MSO for Diversus Health. I'd like to introduce my team, if that's okay. I have Jesse Spires, who is our senior manager. I have Natasha Cooley, who is our care coordination supervisor. And I have James Mobley, who is our criminal justice peer navigator. And Brian Edwards, who is also a peer navigator. Thank you. They're the ones that make the work happen, so I wanted to just introduce them real quick, so thank you. All right, so what does an MSO do? I'm kind of building on what Daniel had already said. We contract with BHA. We're a pass-through for funds to provide the continuity of care for the safety net and those clients that really need it, can't afford to pay, or they're the ones that definitely need the help. So yeah, we manage funds. We subcontract with recovery residents and all of those, all providers for the whole continuum of care. So here you'll see the different continuum, the service levels that we provide. We support 7 different counties, and then you've got the map here. Your Signal has a good portion of that, and this is not the updated one with Boulder.
No, it's technically correct now.
Yeah, it'll change, but yeah. So, all right, this is who we contract with, our providers, and I know it's an eye chart, but even just I've been with Diversus Health for about 10 months now, and this provider list has grown considerably just in the 10 months that I've been here. The recovery residents one is the one that we're the most proudest of, because that one, weekly, we have recovery residents reaching out to us for funding, and work with Kevin and Butch to get their CARR certifications done and get them certified and contracted as quickly as possible so that they can start offering services. So a shout out to all of our providers. And just a brief description of who our clients are. Those I did say that it's the ones that can't afford this to get into recovery. So these are the guidelines, basically below 300% poverty level, and we do look at the priority population, so the injection drug users, pregnant women, women with dependent children, and the involuntary commitments. I would like to turn it over to the peers and let them talk about what they do. Is that possible? Are there mics for?
Let me check with the moderator. Yes.
Thank you.
Those peer support people, we just help people. We walk with them through their recovery. We try not to judge. We just are there for them when they need us the most. We just try to believe in them and get them to the water. We can't always make them drink, but we connect people with inpatient treatment, outpatient treatment, methadone clinics, sober living, everything that might possibly help. RCOs are also a thing that we use. Let's see. I do so many things. I also work at SRM, and we work at the acute treatment unit to help people get into treatment out of there, because that's kind of the bottom line where a lot of our people are. They're all pretty much high acuity now. We're pretty much crisis workers. There's not an easy client. So it's getting really bad out there, and we're just trying to ebb the flow of people and get them in the right place. There you go, James.
Hi, I'm James. I do the same thing that Brian does, except my focus is more on the criminal justice population. And I started working at Diversus Health about 2 years ago, and I got sober through sober living along with Brian. And so when I found out that there was funding for sober living, I made it my task to build a network of sober living homes. The first month we got 3 applicants, and last month we had 211. So it's grown quite a bit. We do have a little process to it. We send out some paperwork, and they can either fill it out and take a picture and text it to me, or email it back, or just take it to one of our offices and have it sent to me. After that, we staff it, and we go over, there's a few questions. There's 2 pieces of paper. The first one is kind of like a past experience of sober living, if they've ever been kicked out. And there's also whether they have mental health conditions, what kind of medications they're on, if they're a sex offender, because all these are pertinent to knowing where to place them. The second one is more about their motivation. Like, what are some goals for your recovery? What are you going to do different to not fall back into the same old behaviors? I forgot the other 2. And I created it, and I forgot it. But after that, we staff it, and it's a case-by-case approval or denial. And when we deny someone, we don't really deny them. We just ask for more information, or if we think they need a higher level of care, we try to get them connected to the Crisis Walk-In Center, or maybe the ATU, which is our acute treatment unit. It's not me, I swear. It's not. So if we deny them, then we work with them to get them approved. And if once they're approved, we can either help place them, or they can try and place themselves. We get a lot of people from CJC, which is the Criminal Justice Center. We get a lot of people from treatment. We get a lot of people from detox. I go down there twice a week and offer resources. We get, DHS, you name it, and we get referrals from them now. So that's the other piece of building the network. So it's gone really well, and we're very busy. Like I said, 211 last month. And from July, August, and September, we've spent over $194,000 on sober living. Thank you.
Thank you, James and Brian. I'll turn it over to Jamie.
Thank you, everyone. My name is Jamie Feld. I'm the Deputy Director for the Opioid Response Unit at the Attorney General's Office. First of all, I'm just so grateful to be at the inaugural CARR Summit. What an accomplishment. Just want a round of applause. Honored to be here with our panelists today who have done a lot of work over these years to make this possible, and for Butch as well. But most of all, for all of you who are in the field doing this work. We know that it's not funding alone that is going to make recovery possible. It's you in the field talking to people one-on-one, you doing the hard work every day to make it a reality. And I know it's not easy. It's exhausting, tiring work. And you're out there, and we can't thank you enough. So round of applause for you all. And for your commitment to this work. In addition to working at the Attorney General's office, I am a family member of a person living in recovery. My sister went through a recovery residence and now works for one and is also a peer. And I full-heartedly believe in the value of the work that you are doing in this room. And Colorado is a leader in the nation, really. So just know how important it is and how vital it is. We are in an exciting time. Where for years, I've been working in Colorado since 2013, we didn't have any money to address this, really, right? Everyone out there was trying to scrap together cents. And now we're at a place where we are trying to address this. The reality is that it's due to the loss that we've all felt. It's due to the deaths that we have seen. You know, all of us have experienced being in this field for some time. And the harms that have been done by distributors, I have up on the screen, pharmaceutical companies, and different malpractice that has happened. We've lost over 1,000, I actually don't know the exact number, thousands of people in Colorado in 2021 to opioid overdose, and the number is just climbing, with synthetic opioids increasing at an exponential rate. We're doing all we can in our field to address this, but we need all hands on deck. One area I do want to just reiterate, we will get to the funding piece, is just I want everyone to know about the importance of naloxone and having it as a resource in your recovery residence on you as something that you can have to administer if there is an opioid overdose. My sister, when she was working at a recovery residence, not in Colorado, she was in a room and someone died of an overdose because naloxone at that time was not available. And that 20-something-year-old is no longer with us today. So that said, again, thank you for all you're doing. And we have a lot more work to be done. At the Attorney General's office, I'm proud to say that our new Attorney General, as of yesterday, Phil Weiser, is completely committed to this work. Thank you. After winning the election, the next morning, we had a meeting with him for 2 hours on the opioid crisis, and this morning, right before today, another 2-hour meeting. He is completely committed to this effort, making it one of his top priorities. And as a result, we see coming to Colorado $520 million over the course of 18 years. This is going to make a difference, and it's going to make a difference in the recovery residents community, and it's going to make a difference in the way that we can support the workforce. I just will briefly mention how we got to where we are. There is something called a memorandum of understanding that the Attorney General and local government set up. He did this as a result of outreach throughout the state of Colorado, understanding that Colorado is a very geographically diverse population, And understanding that the needs in each community is different. So he went to all 64 communities, did, I think it was 19 town halls about the opioid crisis in the last 2 years. And as a result, built a coalition saying that to elected officials, the opioid crisis and substance use in general is something that you all need to be addressing. As a result, there's this settlement distribution where the majority of the funds are going to go to the local level. So 80% is going to go to either regions or local governments. So in a moment, I'll just show you a map. It's important for you to connect to your regions. And the 10% will go to something called an infrastructure share, which I'll share about in a moment. And then 10% only 10% is going to be held at the state level for different projects. Some we know about are like a criminal justice roadshow to encourage criminal justice diversion and also addressing medication-assisted treatment in jail, some innovative programs, things like public awareness for youth. But the majority of the funds, like I said, are going to go to the local level. Here you can see this map of the regions in Colorado. The regions were able to identify themselves and how they want to form. So they decided not to always go in the same manner as the MSOs, which is a challenge, right? Or some of the RAY regions. But they determined that this is the format that they wanted to use. So it's going to be key that these partners look at other funding from the Behavioral Health Administration, from their MSO, to make sure that they braid and leverage the funds. So each region had to turn in, or is in the process of turning in a plan. There's a couple different oversight committees that look over these funds to make sure they're used in the proper way. We don't want this to be like it was with the tobacco settlements, where we didn't see funds going towards tobacco prevention. Our office and nationally, there's a commitment to make sure that these funds actually go to opioid remediation and to address people in recovery and getting people to that point. So we have a dashboard, and this shows where all the funds are going. If you have your, maybe not yet, don't pull your phones out yet to do this, but afterwards at the break, take a look at it. It's on our website. And it will show you also who to contact in your region. If you want to say, who is the key stakeholder that I need to be reaching out to make sure they know about recovery residents and why it's important. And I will say that many of them already have included funding for recovery residents in their plans. So when you go to the website, it'll look like this. It'll show how much money is going to each area, the plan that was submitted. It'll show how much we're using at the state and at the infrastructure share, with the key being transparency. We know that $520 million is a lot more than we had before, but the staggering crisis we're facing, that this money is actually not enough. You know, it's not fully enough to address all that we need to do, and it's not enough to really address the workforce, right? We need the workforce that we have here today, and we need it to continue for many more years. So just quickly, some of the allowable uses are above: prevention, harm reduction. We know that not everyone is ready for recovery, and these funds can be used for harm reduction prior to someone being in the place for readiness for recovery. Treatment, evidence-based treatment, criminal justice, so things like medication-assisted treatment in jail or in criminal corrections. Recovery, we'll go into that in a minute. And then community leadership. Things like staffing and training can be a part of this. So there is, this is just pulled directly from our plan about allowable uses. And you can see that it says very clearly the full continuum of care of recovery services for opioid use disorder and any co-occurring substance use or mental health issue, including supportive housing. There's a couple other areas: identifying successful recovery programs, supportive housing for treatment, all forms of federally FDA-approved medication-assisted treatment. So very clearly, this is an allowable use. So one more funding opportunity. I just put this in. Butch was grateful, kind enough to let me sneak in another slide at the last minute. But this is really key because it's a new funding opportunity just released November 1st. The Attorney General is committed to getting the money out as quick as possible, and he's put us on a strict timeline. He said, we got to get this out posted on November 1st. so that the money can be available. And it's an infrastructure share to promote capital improvements and operational assistance. It's really to encourage regional collaboration. So, we have these 19 settlement regions, but we want collaboration between the regions. And then also for the most underserved or under-resourced parts of our state. So think through this. This is the first year they prioritize brick and mortar for these funds. And then it will be continuing for 18 years. So there's a period of questions between November 1st and November 21st. You submit it through a Google form online. We're doing that just to make sure we give consistent answers to everyone. This is the key time period to be asking your questions. Just another plug for a website we have about resources. On there is a variety of stuff about recovery and how to ask for Oxford houses, for example, craft facilitators, links to the Behavioral Health Administration, links to the various MSOs that are such a key partner, and some resources about how to braid these funds, because we know that our funding stream is just one source. You really have to think thoughtfully about how are the funds from the Behavioral Health Administration able to pay for rent, perhaps, so you don't need to use opioid settlement funds for that. I'm getting to it too. I'll leave Mark for his part, but for you to know that there are different funding sources from SOR, the State Opioid Response, from the Behavioral Health Administration, and that the opioid settlement funds are fairly flexible, so they can help fill in some of those gaps that you might not be able to pay for, like infrastructure or capital costs, or maybe the first month before someone is able to really get that rent subsidy. So I already got to this slide, but we are trying to follow best practices. Again, knowing recovery residents, recovery community organizations are a key part of this issue. And it really is best practices, as we heard from earlier in the morning. I'm not going to go into this timeline in a lot of detail, but just so you know, the regional plans, there was a rolling submission, and most of them, I would say 4 plus 12, 16 of the 19 regions have now submitted their plans, and funds are starting to be released from the national administrator. And they have the opportunity to amend their plans in March. So between now and March, get in front of your region, say, hey, have you thought about regional recovery residences? They have the opportunity to still amend their plan. And we will continue to have ongoing technical assistance. We'll have a conference next in August. We had one last August with a lot of speakers from recovery. I think Rourke is here today. He spoke. We had Butch was there, and we had some various behavioral health administrator folks, but we want to make sure your voice is in the conversation. So I'll just leave it. I think I went a little bit over, but just again, a huge appreciation, because we know that we're in an incredible crisis right now. Someone can use a pill, think that it is, they might think it's a Xanax, an oxycodone, something is prescribed, and really it contains fentanyl. And the increase that we're seeing in these deaths is 58% increase from 2020 to 2021, and I'm concerned about what we're going to see in 2022. So it's an all hands on deck situation. Thank you for your work, and thank you for all you are doing today.
Good morning. It's still morning, I could say that. I am so excited to be here. Thanks for including me in this inaugural event. This really is a celebration of the work that you're doing. I'm thrilled that I got to play a tiny part in supporting it along the way. But really, it's the work that you do. I'm Mark Conajani. I'm the Director of Adult Treatment and Recovery with the Behavioral Health Administration. I use the he, him pronouns. And I say that title very confidently these days. When we did one of our 15 reorgs in the 20 years I've been with the state, and I got to lead a new team that was focused on purchasing of services, and I was very deliberate wanting to have it called Treatment and Recovery. I saw where we were going. I saw where the gaps in our system were. I saw after Medicaid expansion 8 years ago that there was an opportunity. Medicaid was going to start covering for SUD treatment services that in Colorado had not been covered until that point. And then a couple years ago, the benefit expanded to include residential treatment. So the full continuum of SUD treatment was being covered. So a bunch of years back when we were reorganizing, I said, we need to be moving in the recovery realm. We need to be looking at what recovery community organizations can do to really help people sustain recovery. Treatment's essential, but there's more. What about safe, supportive housing for people? Whether that's recovery housing, democratically run like Oxford House, or kind of the NAR certified 2, 3, and 4 where there's staffed models. We didn't have that, or we had very little of that at that point, and it had grown organically. I want to talk about the new age we're in now. Now the state agency I work for, I haven't moved my desk yet. That's going to move eventually. But Colorado has made some massive changes. We are now the Behavioral Health Administration. Colorado really took a look at the fact that, what an amazing place to live Colorado is. In a lot of ways, we are some of the healthiest population. We enjoy outdoor living. But when you look at behavioral health, Jamie just talked about the overdose rates. The suicide rates in Colorado are crazy. And then when you look at survey data in terms of people who needed help for mental health, for substance use, and couldn't find it, it's just plain unacceptable. And so our legislature and our governor got to work and said, we need to prioritize it. We need to create basically a behavioral health administration where its leader sits on the cabinet and influences every other cabinet member, from the Department of Healthcare Policy and Financing. That's our Medicaid authority. That's an important one. Department of Corrections, all of them. Our commissioner sits with those other leaders and together kind of identifies is the entire state administration focused on doing everything we can to help Coloradans. So our organization, we have a purpose, vision, mission. All people in Colorado deserve to experience whole person health. Behavioral health services in Colorado are accessible, meaningful, and trusted. I'm going to come back to this when we start talking about your industry. Accessible, meaningful, trusted. And then our mission is to co-create. We're not doing it ourselves. We're not in our ivory remote office tower in Denver, just deciding for all communities of Colorado what they need. No, we need to actually engage with our communities and co-create a people-first behavioral health system that meets the needs of all people in Colorado. I mean, that's profound. And right now it's words, right? So you need to hold your government, me, accountable. And we welcome that. Here's some of our values. Collaboration is key. Community-informed practice. So we've talked for a long time about evidence-based, right? Evidence-based practice. And certainly, I've been promoting it. I've led our state opioid response efforts for a number of years in Colorado, trying to make the gold standard in treatment, which is medications for opiate use disorder, available. When we started that grant in 2017, half of the counties in Colorado had 0 access points for medications that treat people with opiate use disorder. Today, there is 1 county that does not. And one of our mobile health units drives right up to the border of that county. Okay. So community-informed practice is really important. The division that I work in now is statewide programs, innovation, and technical assistance, okay? So innovation and this community-informed practice, this is the bringing together of saying we've got to listen to communities about what works. And that means listening to recovery communities. And that is a breath of fresh air. We need to listen to the people that are walking the walk. okay? Government didn't create the Phoenix. Government didn't create Oxford House. Government didn't create other sober living. Government didn't create a lot of other RCOs. A lot of them they started organically, innovation, community informed. And then eventually government got our head, we'll say, out of the sand, because, someone might be recording this, right? And said, people seem to be responding to that stuff. It's making a difference. We should pay attention. And so we've been able to start making some progress and follow you. And not just follow you, but try to support and walk alongside you. Equity is a really important thing that we're focusing on as well. And that involves naming the root causes of injustices and allocating the necessary resources to support desired outcomes. Those are some tough conversations and some tough reckonings that we all need to have, but we are focused on trying to address some of those issues. And then generational impact and truth, okay? We have to be honest with you. We can't just talk about our successes. We got to talk about where we're struggling. We got to be transparent when we make mistakes, and then hopefully together with you build that trust so that we can move forward and self-correct. And that generational impact, this is something that's really powerful. We're not just trying to help the person in the room, and we know that in the recovery realm, right? We know that in the addiction realm. When you help a family member, a dad, a mom, on their recovery journey, you're not just helping them, right? You're helping that next generation. And that's really where we want to put our focus. Can our interventions, can the things we invest in have that generational impact? So investing in recovery, just a quick little brief history lesson. So, a number of years back, I forgot when, it was quite the battle back in the day where we finally put into our block grant application. Every state gets an application, gets a grant from the Substance Use and Mental Health Services Administration. And because Medicaid expansion had happened, I said, we need to invest more in prevention and recovery because more of treatment's covered. Treatment community wasn't thrilled initially because they just saw that as, wait, you're cutting into our money, right? But we made that commitment and we started to put some money out through some grants. It was very small. It wasn't where I wanted it to be. Then when the opioid grants came about and they were foolish enough to let me lead it, I got to put some budget in there too and say, you know what? We learned some things from that access to recovery back in the day. Let's start working to hire some outreach workers from Oxford House through our MSOs in parts of the state where no sober living existed, right? We were able to get some funding from those grants that also went to recovery community organizations. It's not one or the other, right? It's all. And then, of course, the legislature asks us, OBH at the time, to select a certifying body using national standards to regulate recovery residences. And that was a monumental moment. And again, it didn't happen overnight. Some guy named Rourke, perhaps you heard of him, always chirping in people's ears, trying to figure out how to advance, his goals, his dreams for greater access to recovery residents and recovery in general. And he asked me, so how do we get money? Because all these treatment, how do we get money at recovery residences? And I was very direct. I said, right now it's the wild, wild west. You can do what Utah did, which is pass a law that all recovery residences get licensed, or you could do what a lot of other states did, which is follow national standards like NAR and pass a state law to get certified, because government's not ready to put money into an industry that has no oversight. Remember that thing I said about trusted, right? Services have to be trusted. So the first effort was, hey, let's try to get licensed. And first walk through the legislative process was a little choppy, and the price tag that CDPHE, Public Health and Environment, that regulates most healthcare organizations at that time, they put the price tag on that was really high, and whoever was pushing that bill said, well, let's take a step back and think this through. And that's where they came and spoke with, said, well, let's explore this other option. And they looked at CARR, they formed CARR, started early, and then were able to pass some legislation. And we're glad, because what happened next? Once that was passed, more opportunities came. And this was the first round, Senate Bill 21-137. It did a lot of things using the American Rescue Plan that President Biden signed into office, or signed in the spring of 2021, but it also includes some ongoing funding. That's a really important thing in state budgets, is it had $1.6 million annually dedicated to support recovery community organizations, and $4 million annually to support people who can't afford it to be able to stay. And the way we operationalize that is either at a chartered Oxford house or a CARR certified recovery residence. Because again, we're putting our trust in CARR. We're putting our trust in that charter that Oxford House gives, that democratically run, those democratically run houses, and the staffed facilities that are CARR certified are going to be safe, and they're going to be meaningful, right? That other part of what we're talking about. So that's been, that's huge. It's a big difference. But we're not done, because our state legislature in Colorado prioritized behavioral health with a lot of those American Rescue Plan dollars. And this past legislative session, they gave us a bunch, and we're going to be releasing an RFA. That's a request for approval. That's how you get our money, okay? And I want you to go out and get our money, okay? Again, like some of the other things that have been talked about from Jamie, this is a rare opportunity because it can be used for capital expenditures. The problem with these dollars is that they're short term. They got to be spent in a couple years. 90 million in a couple years. That's quick, right? But this is an opportunity to be thinking about where are the gaps in our system. And there are three grant programs. Community investments, which is really looking at any gap along the entire continuum, okay? And for any age population, by the way. So it could be crisis services, it could be harm reduction, it can be treatment, it can be recovery, including recovery residences. It may be a small dollar amount. Perhaps the only thing keeping you from getting that CARR certification is the right type of windows or whatever you need or whatever, and that's a capital expense that's a pain in the butt. Ask for our money, okay? And make the case. We don't have enough recovery residences in our community. We've talked to our MSO. They agree. They're willing to contract us with us as soon as we get opened. We've talked to CARR. They're willing to certify us once we make these facility improvements at the structure that we're looking to get. These are opportunities, right? The next one is children, youth, and families. That's 39 million. You see, the first one is 34 million. 39 million. That's, again, looking to fill identified gaps on the behavioral health continuum of services specific to children, youth, and families. This is another opportunity where you think of where do we go next? Are there specific populations, again, thinking about equity, that would benefit from a recovery residence that's for them? LGBT community, there's a lot of stigma, a lot of barriers. It could be for specific racial groups or others. Obviously, you got to have fairness, whatever, but we know there's populations that are underserved in Colorado. And putting a recovery residence in an underserved community could be really beneficial. And when we think about children, youth, and family and multi-generational impact, Oxford House has, men's and women's houses that can include children. Is there a recovery residence model that could be for women with their children? Help them recover together as a family unit? Don't know. This is where innovation comes in, and hopefully CARR's got some standards that would allow for that. But those are some of the opportunities that could be explored in terms of how you might seek funding from that particular grant versus the community investments. grant. And the other one is around SUD workforce, and that's $14.6 million. That's funding really to support pay increases for the frontline SUD workforce. And what is frontline SUD workforce? We're kind of defining it as, well, anyone that works at a program that treats or provides recovery services to people in recovery. It could be for professionals that are certified addiction technicians, certified addiction specialists, licensed addiction counselors, or hey, how about a certified peer? So peers that might work in your facilities, as well as addiction counselors. You're struggling to have a living wage or have some pay. This is some funding that can help you increase that pay, have some retention bonuses, et cetera. So in the next couple weeks, we're hoping to release this grant. I got a meeting at 1 where we're trying to clean things up and get it ready. We're really excited about this opportunity. With that, I know I left a little bit of time for you guys to pepper us with some questions, and that's that part where you hold all of us accountable. Here's a couple little things around staying connected with the BHA, because we're all into the social media these days. So, thank you.
So we want to open it up for questions, but I'm going to take a run at a couple questions for the panel as you're thinking about those, and we'll kind of go through that approach if that works. So just a few softballs to start. So when we're sort of thinking about the evolution of growth in access to recovery services and recovery living specifically, a lot of these are funding sources that are grants or at times one-time money or at times ongoing funding. How do we build access to care that lasts, that is able to identify what sort of, the finish line or the goal for the total capacity in the state that reaches everyone that needs it, that reaches all communities, that there's a health equity frame around all that? How do we think about that?
Want me to take first stab? Okay.
I was thinking maybe.
And again, there's all these different funding streams that we've talked about. You got the Attorney General's office with those regional entities that are able to make those funding plans. That's a number of years, right? The most important one in terms of health care in Colorado is Medicaid, because anyone that's at up to 133% of poverty is eligible for that health care insurance plan. And that health care insurance plan covers pretty much all behavioral health services. So but it doesn't mean it's available, right? Just like I mentioned on the opioid thing. Hey, Medicaid covers methadone treatment, buprenorphine treatment, Vivitrol treatment, but it isn't available in half of our counties. And in our biggest counties where we're having the most losses of life from overdose, there's not enough access points in those big populated areas either. So you need to build thoughtfully, and that's where our dollars through these funds or through our MSOs, when they have money that they get annually that can be used to build capacity, you want to be thinking that way of, am I going to do a service that's Medicaid covered? If yes, great. Let's make sure I'm talking to the Ray people and make sure they're going to contract with me when I build it with these short-term funds. And when it comes to recovery residences, we know there's that $4 million that can support people to stay there. Be thoughtful about that. Should one person stay in your facility for 10 months because you might be able to access some funding? Would you be having them stay there for 10 months? If you didn't have this funding, is that really a part of their recovery plan, or do they need it for the first month while they get it? And your model includes maybe they get a job and start moving on with their lives, right, and building up their own equity. So be thoughtful about how you utilize these funds so that they are able to spread out to as many people as possible. But these types of short-term infusions of funds can be used to create additional capacity. Let's build another facility in this part of the state where there isn't one or where there isn't enough beds. Let's talk to our MSOs to make sure we'll have a contract to support people that need it once we build it with these funds.
I would just add short game, work with your MSOs. Medium game, think about this grant at the Behavioral Health Administration. There's something through the Colorado Consortium where they have a grant writing assistance program. So if you're feeling overwhelmed by all these grant opportunities, They can help connect you with a grant writer. That resource is on our website. And then long game Attorney General settlement funds are through 18 years. So start building those relationships with your regional council. And I think I would encourage you to think big. This is a situation where we are having a lot more money in this period of time compared to when I was working in this field in 2013. Think big, think about the gaps you're seeing, what communities are not being reached, think about how you could grow. I think there's a lot of opportunity, but what we need people to do it, and we need people that know how to do it right. And then navigating it can be challenging, but we are all resources. So in the slides is the email from my office, and we can help you figure out how to navigate at least our portion and then connect you to the resources at the different levels.
So I think just to kind of add to that, meeting the client where they're at, remaining client focused, I think is a big key. Collaborating with and networking partnerships, those all help us provide that equity that I think is crucial. So I think that's my part.
It's really helpful perspectives from everyone. I think we have until 12:20 or so. Butch is gone, so I guess unilaterally we'll go for that. Yes? Is that Rourke says yes? So okay, cool. I'm curious about questions from you all. Yeah. Mike is coming, or you can shout something.
Quick question about the statutes on kind of like the bed tracker. I've seen some of this alluded to on the various different websites for care organizations, and so a detox facility can see availability. What's the lead time or expectation on that?
Mark?
Wow, a tech question. I'm not the guy for that. I don't have that answer. I'll research it with the people building that system and what those expectations are, and I'll make sure to get it out through Butch. So, sorry, I just don't have that answer right now.
I think part of the objective broadly, though, is just to have better connectedness across levels of care and having a better vision of that available to more organizations too.
Yeah.
I don't know what the time frame, but yeah, I don't want to.
Yeah, I mean, the original statute that said, hey, we need to have a bed tracking system, it didn't call out recovery residences at that time. It was looking at psychiatric beds, withdrawal management beds, residential treatment beds, et cetera, et cetera, et cetera. But I'm certainly the one that's thinking bigger about what about this? Like, let's think of the continuum more broadly. And when, if we're going to build this, make sure we build it with the capacity to add this additional component. But hopefully at least that portion will go live fairly soon so that when you need to access, you can find all the residential programs that are licensed in the state. You can see if they have any bed availability, so you don't waste your time calling 15 programs that have massive wait lists, et cetera.
Yeah.
John Reed with Heart Mind Haven. We're one of the many fortunate community-based recovery organizations that received this amazing support to make a difference. In terms of working with transgender individuals in recovery, it's a daunting task, and I just need to be careful about how I'm going to preface this remark to all of you. I'm deeply concerned about the health equity and the equality. As we're dealing with recovery residents in our community that are dealing with an enormity of other health-related conditions in terms of their physical and emotional transition into whatever they're choosing, we're confronted with so much stigma around linkages to care in the primary care community as well as in the mental health community. I mean, it is atrocious when I can't even think of this one resident without getting emotional about it. There I am at one of our local hospitals 2 and 3 times a week because we dealt with what seemed like an endless cavern of readmissions. into this hospital. I go onto the ER unit, and they're still referencing this individual as him. And I'm saying to the charge nurse and to the other people on the floor, this is this individual's chosen name. Please use their acronyms. Please empower them to get well. And I don't want to be long-winded, but what are we doing collectively to not only educate people about the importance of gender identification and having people use something as simple as what that person, what that individual wants to be referenced as. And then I go in, I use her name, and nobody knows who she is in the freaking hospital. And do you mean, and I look in the room and I didn't even recognize her because they wouldn't allow her to shave. I mean, that's what we're dealing with on a grassroots level. And the funding is great, but how do we shift that paradigm where we're empowering not only the community, but we're actually creating equal opportunities for individuals to feel themselves so they have a chance at recovery and have a chance at other opportunities. And this is to the Attorney General's office. We're still dealing with a vast amount of people that are experiencing barriers with legal name changes. It's hard to get them on Medicaid. It's hard to transition them into independent care for themselves without having the appropriate ID. And I'm telling you, there's so many barriers that prevent people from obtaining legal ID in a period of time. That's not only, it links to medications, it links to primary care provisions, it links to behavioral health, it links to pharmaceuticals. You need that ID. So that's my soapbox, and I do appreciate all you do. We feel fortunate, but there's some untold problems out there that are not being dealt with.
I think it's such an important focus, and I'm curious. I don't mean to keep kicking stuff to you, Mark, to start with, but equity, one of the values of the BHA. How do we address this important matter?
Together, and thank you, because you just spoke about an unspoken barrier, and that's what we need to do. We need to bring it up. We need to advocate. We need to see the humanity in everyone. And change isn't going to happen immediately, but we're going to be persistent. So again, bringing that, continued awareness to it, how we conduct ourselves individually. I try to, I've got a couple of team members at the BHA, one who's transitioning, one who's non-binary in their gender identity. We've gone through our own kind of cultural awakening to really be more respectful and more supportive. And that's been a very healthy process for us to kind of recognize that, all right, we saw our own struggles here on how we figure this out together and move forward together. Now we got a whole lot of work out there because every system is not set up to kind of be supportive. And so we do it piece by piece. We find those networks, we find those healthcare providers that are supportive. You try to make inroads into a hospital, and maybe one that's got many different hospitals in their system, and then you pilot it. That's what we did around initiating, I know it's completely different, but initiating, it was still a cultural shift. Initiating opioid treatment in a hospital setting. Oh, that's not our role. Like, we just deal with the emergency and then send them out. Send them out to what? They just had an overdose, right? Like, get them started on care and then do a warm handoff, just as you would when you fixed a broken bone. You would put the cast on, and they would have a follow-up with a healthcare provider. Do that thing for addiction. Well, the same thing needs to happen in terms of good healthcare services for the transgender community. So we got to start somewhere, pilot, develop those best practices, and then work to spread and do it consistently.
Check. Oh, there it is. I'm Mary McRae. I'm the founder of Heart Mind Haven. I have a transgender daughter, and she was assaulted in our mental health hospitals, our largest Medicaid hospital. And that's what inspired me to open Heart Mind Haven, where people can have a safe, inclusive, exclusive. They can't heal without that, with the fear. And I just want to add to the room of recovery residents, that's why we're here, is that my experience before I opened Heart Mind Haven was with my daughter going to a sober home and going in, and they allowed her to come into a female's unit. However, when they were doing the UA, stated like this man had to watch her do it, her UA, and she stated she wasn't comfortable with a man watching her. And they basically said, I'm gonna say this really bluntly because it was mind-boggling to me. Do you still have a penis? Because if you still have a penis, then I watch you. This is what he said. And it is really incredibly hard for somebody struggling with addiction to take the step of going to recovery living. That's scary. And then you add LGBTQ and trans, and that is amplified. And I was shocked out of my mind. I did email CARR about it. However, then I took a little questionnaire and I called 6 recovery homes, just random, and I asked their protocol of a trans coming in. So my daughter, trans female, and they all said, yeah, our protocol is if they've had lower surgery, which is really identifying them as a body part, right? So I just want to address that to everybody in here. It was a huge reason why I started Heart Mind Haven. And the other thing, really quickly, because I know everybody has questions, but Mark, is there any kind of talk about working with the hospitals around involuntary commitments and people that aren't in compliance with their involuntary commitments? So they come from 120 days inpatient and they have to do their mandatory IOPs and be there and do their UAs. But what's happening when they fail from that is if they end up back in an emergency department is the hospitals say, this happened to me last night at Swedish, oh, what's an IC? Even when I had the manager of the emergency department. And with my daughter, OBH now, I know a different name, BHA, has spent $1.2 million $1.2 million on one patient with 97 ER visits in 2.5 years. And I just want to throw that out because we're talking about money and what could happen if that money was put in. So I just see a big barrier of educating. Maybe the governor could get involved, but having the hospitals also be accountable to this court order, that's just a huge break I see. Because a lot of money is being spent, and we should take that seriously, that these people are severely ill or they wouldn't be in that situation. And I'm so frustrated with that continual cycle with hospitals and not even knowing what's an IC. I mean, even IOP, we know that there's a lot of education around psych beds, but that was something I wanted to add. I thought it was really important why I had you here just to voice that, so thank you.
You bet. So there's a couple things I'll say quickly about the whole process, and this affects everyone in behavioral health, is that care coordination kind of stinks because it's always been turfed to who the payer is. Okay, so if you got Medicaid and you went to a mental health, psychiatric hospitalization or SUD treatment, but then you go to sober living, Medicaid doesn't pay for that. So how's that work, right? So we're trying to figure that out on a big scale. And in terms of the substance use IC statute, which is I think what you're speaking of, versus the mental health statute, because it's different. But we play a big role with our MSOs at managing those cases. Yes, we actually just got 2 new positions and a mandate in the fentanyl bill. That is dedicated to going out and training law enforcement types and medical hospital people about the IC process and how to use it. We also know that that's going to generate a lot more business, so those 2 positions are also going to help us manage that caseload as well with our MSO partners. Okay.
Just real quickly adding to some of the remarks too, I think we sometimes say the behavioral health system as if there is an actual one thing. And in reality, it's a constellation, right? And we all experience that in different ways and different limitations. And a lot of it is born, I think, out of a history of funding services and building services through grant-based approaches, which we still largely, honestly, utilize. And that's important, and that is better than not having any investment. I think the direction that Colorado is trying to go in is having a long-term, sustained, actual system that is hopefully one, that's hopefully unified, and most importantly, not so much focusing on the fact that it needs to be a unified system, but rather we need to build funding in a way that supports individuals, not finding individuals to support funding. And that's too often, I think, what happens, and that's how we leave people behind, and that's how we don't have the level of attention and inclusivity that we need to have, I think. And a lot of it is not intentionally designed to sort of leave people behind. It's just sort of where we're at, and we have to continue to not lose our drive to get to where we have equity that we need to see. I think it's really critical.
And I'll just add just appreciation for the work that you're doing and the question that you raised. We know we need more culturally competent care, and you just highlighted that, and we need it throughout the state. We need to have not just one place somewhere someone could go, but multiple places. And so just encouraging everyone to think about how you could create more culturally competent care for people that are non-binary, that are different identities. We know we're not meeting that need right now in the state. And so how can we do that? And then second, just to offer at the end, I'll give you my card to make sure that person's rights are being protected, their legal rights. We do have a constituent services branch, and our office is committed to ensuring that people's rights are protected. And there's an ombudsman program at the state too, and we want to make sure that all those are being heard and being taken care of. Thank you.
Next question.
Hi, Derek with Rad Recovery, co-founder, my business partner right here. So this question may be kind of parallel to actually what they were asking. What kind of behavioral health training do you provide operators and staff, and where can we go for that?
I hesitate, Mark, but I know there's a learning academy. Possibly.
Was that training that was asked?
Yeah,
It was
yes,
training?
yes,
Okay.
yes. Sorry.
So, very cool. We are, with past funding, we've been in the process of developing a learning management system, which will be an online system. And we'll be able to house, there'll be some initial basic curricula that will be housed there that people can do self-paced learning, et cetera. Kind of get credit for your continuing ed for whatever your certification might be. And the options are limitless. So each aspect, we're already working. We submitted a grant application to develop a set of curriculum for people that work in crisis behavioral health. And it's really designed so that whether you're a peer or a licensed person or whatever, you can go through this set of training, and then our licensing standards for crisis services will say you need to have someone that's leading this crisis intervention that's completed this curriculum, right? So I can easily see this being used by other aspects of our industry, including recovery housing. I think it could be an option to take some of the content and the training that CARR is already providing and find a way to, digitize it, put it up there, host it so that every staff at every CARR facility can kind of learn the basics of standards, but then also look at best practices and other types of things and start, even putting in some of the work to get certified as a peer. I think there's lots of opportunities once that's built, which we think will be by July. We'll have that system up and running with some initial content ready to rock and roll and limitless opportunities.
Just to put in a plug for the Colorado Providers Association, which supports a lot of that. Bree, I think you're talking later, so I don't want to steal your thunder, but Sydney and Jacob back there at the COPA table also offer a lot of support around continuing education and training for peer professionals as well. So, other questions?
There he goes. My name is Bobby. I am in Canyon City, the rural communities, right? how do you support the rural communities where we can't charge clients that don't have the capabilities of paying? Like, just even trying to maintain a house in the rural communities that can't? How do you?
Talk to your MSO and get into a contract with them so that they can help pay for rent for the people who can't afford it, right? So I don't know what the mix is in different communities in terms of what percentage of your population are able to self-pay versus those that are going to need that financial assistance. But that's a business model that you got to figure out. But I think that's what we're invested in terms of that access piece. We know that there is limited rural access, and someone that's brave enough and has the heart to open one up in that community, we definitely want to make sure you get CARR certified, you get connected with the MSO, and you figure out a relationship where you're able to provide some financial support for those that need it.
Just even maintaining the house itself.
Yeah. And I think this is one of the parts where CARR can kind of help other members in terms of, because everyone's gone through some of these growing pains. We charge $600 a month for rent or $800 or whatever your charge is, depending on what kind of level of facility you have. And, that's figuring in your, if you have a mortgage or if you have a lease for the property or whatever the situation is. But have you factored in food? Have you factored in your electricity bill? Apparently they want to watch TV, so is that Netflix or cable? Whatever all those costs are, that's that business model piece of more mature facilities kind of figuring that out and then being able to say, I know we'd like to make the rent $600, but really, if I'm having to cover some of these additional expenses, the rent has to be a little bit higher, and if that's the case, how do you now what, right? Okay. And that's the discussion. If you can show what your costs are and why you've set your rent at the rate you are, you can talk with your MSO saying, hey, I need it to be a little bit different because of this. And then there could be other facilities in this room, and we should be sharing and supporting each other, right? We're in this together, right? Especially unless you're ready to run up to Canyon City and open a place, but here's someone that needs a little help, and you can kind of say, here's how we dealt with food. Here's how we dealt with some of these other expenses. Here's the partnership we made with a local either food bank and or, place that gives free clothing so they can go get, job interviews, whatever you need, right? So those are the types of experiences that can be shared to kind of help you figure some of those things out and be more sustainable going forward. And I don't run a recovery residence, so I don't have that expertise, but I know a lot of cool people that do. And so my hope is that people will reach out to you after this question and say, hey, let's talk.
Done.
Yeah, and I wanted to address that. I've been working with Bobby for a few months now. In those rural communities, these clients have limited job opportunities, and I think that's kind of what you were getting at. We do have programs available for skills training and employment opportunities, so please reach out to us and we'll try to work with you on that. The IPS program is the one that stands out the most to help develop some of those skills so that they can learn maybe try a different route for employment opportunities. I know those employment opportunities are limited down in Canyon City, but I think we can probably help them. So.
Yeah, I'll just add a quick, additional comment. I think, I think I said at the sort of beginning of this discussion that we are seeing growth and investment for the continuum of behavioral health in the state, including recovery services, and that is incredibly wonderful to see. But we also know that we're nowhere close to where we need to be in terms of access and supporting everybody that needs that. And I think that being sure, Mark said this, being sure that you're making your voices heard in the stakeholder discussions that the BHA is hosting, especially to make sure that there's commitment of funding of the state to have a truly systemic investment that takes into consideration all communities, especially in rural areas. There is a huge lack of access to recovery living in rural areas. We've been able to put some investment into that, but it's it's nowhere near where it needs to be, and we need your help in being able to make that case. So please make those voices loud and clear. Other questions? Did I see a hand? Yeah.
My name is Mike with Rocky Mountain Sober Living in Colorado Springs. My question really is, what do we do with the folks that come in that have mental issues? They come into the house and we discover it after the fact. Case in point, we had an individual a couple of months ago who had a severe traumatic brain injury as well as schizophrenic. And we were trying to place him elsewhere, but it's not easy. And where do you send them?
Take it away, Mark.
I'll
I
solve
said
all
I was
your
going to send
problems.
all the hard questions downstream.
I'll see and hear all your problems. I don't know that I got the solution right away, but we're dealing with co-occurring disorders, and you're dealing with more than one, more than two, right? And we're doing a lot of work right now, looking at brain injury and figuring out the intersections with behavioral health. And guess what? They're tremendous, right? 90% of people who are incarcerated have histories of traumatic brain injury. So that's one piece, and then yes, the mental health services. And this is another piece where you've got the recovery world kind of organically grew on its own, largely to fill the unmet needs that the service system either couldn't or didn't fill. And what we're trying to do is integrate that continuum. And just the fact that we're making it so that at least an MSO has a relationship with a certified recovery residence with some financial support. They've got, particularly in Colorado Springs, they have a relationship to a local mental health center, right? So there's, we'd like to see those opportunities where there's greater collaboration. We're not going to ever get to the point, I don't think, where we'll have a specialty program for every instance. But if we work together and find ways to collaborate and, get connected to some of those services, which can include whether it's an ACT team or whatever, if they're appropriate for that, where that service can come right in to the recovery residents, offer some training to the staff to support them of how do I help this person? I'm struggling with being able to meet their needs. But then also to offer some of those additional services that you're not equipped and expected to offer. Make sure that they've got the medications that they need, that it's being managed well, they're getting case management support or anything else that they might need. So that's the vision we need to get to. It's not there right away, but the first thing is to say, I need help, right? And so thanks for speaking up. You said it in front of an influential person from Diversis who has some connections in Colorado Springs. So that's helpful.
I would like to say, my name is Sharon. I'm from Centennial Mental Health Center in Fort Lauderdale, which is a rural, I think I'm loud enough. A rural community. We do in our sober living house do dual diagnosis. We do therapy in the homes, group therapy in the homes, case management in the homes. So that might be able to help you as a place. We have our own med providers through Centennial. We accept Medicaid. And our program fees are $400 a month. And we've used the scholarship grant for our monthly program fees until our clients get a job. So I have cards if you guys need.
Thanks for sharing. Another takeaway is come to the CARR conference at any convenience and make these kinds of connections. This is good.
Absolutely.
Butch, we got time for one more question, you think?
Sorry. Is that okay? Yeah, my name's Cody. I'm with Monarch Sober Living. A couple of quick questions just about some of the funding that the Attorney General's office is doing. I saw a few different things there. I saw Diversis is currently working with those southern counties in order to focus on any of the funding that's going to be coming up to have that continuum of care for the northern part of the state, anything north of Denver. Is that stuff that we work directly through Signal with in order to handle that? That's the first part of my question. And the second part is I noticed that there's, different, obviously on that map, different funding for different counties. And there was just a few dates as far as application dates. Is each county going to release their own specific application date for things that are coming up? So those are my two questions.
Jimmy.
We didn't make it easy at the state in a lot of ways. And the opioid settlement funds do not go through the managed service organizations, unlike other state funds. And how it was set up is it goes to the regions, and the regions are comprised of elected officials and advisory members. So each of these 19 regions has their own regional council of elected and advisory members. The aim is that those advisory members should be composed of recovery residences, RCOs, people in recovery, treatment providers, so they can inform how those plans are made. That's the goal. But that council is the one that decides how the funds are used. And they have these rolling submission dates. All but 3 of the regions have submitted their plans thus far, and they can amend it March 15th. So a lot of those plans have kind of determined how they're going to use the funds. And several of them, I will say, it depends. If afterwards I can ask you where you are. Some are identifying an RFP, just a general RFP that's going to go out to the community and say, hey, we need X, Y, Z. And then they will set their own timelines. So stay tuned. When you go to our map, there's a primary contact for the region, and that's the best person to reach out to for wherever you're at.
I was going to say that map, I think, is really helpful, like, on the Attorney General's website. So, yeah, really great. Well, I think we're at our time, right, Butch? I really appreciate the opportunity to be here with you all. Yeah.